Good evening, everyone. It's a real pleasure to be here tonight with you for this webinar. And first of all, I would like to thank all the participants. I'm glad you made it. Tonight, we are going to have a session that was organized by the GECO, the French group, study group for the bone surgery. And our group is very excited to share and discuss options about post-operative care in the field of arthroplasty, with a specific focus on the new generation arthroplasty, which is a viscoelastic disc arthroplasty. So tonight we have three excellent speakers. We have Dr. Biren Desai from Cologne in Germany, Professor Jean-Yves Lasnec from Paris, and Patrick Tropiano from Marseille, and me as a moderator from Assistance Publique Hôpitaux de Paris. The program tonight is in three parts. We have a first communication about the lumbar prosthesis, explaining the principles and challenges of the postoperative course. Then the cervical prosthesis, same design, principles and challenges of the postoperative course. And a third presentation about the a case presentation for seeing about outliers and risk for specific patients. Then for this webinar, we have all the possibility to ask question or ask for further explanation on the chat on the right. You will have a small survey. If you click on the poll on the right, you can switch from the chat to the survey and answer a few questions. First of all, before we get started, and in order to know each other, because we're not in the same room, unfortunately, and I would like to ask three main questions to the audience. And if you would like to vote, are you user of disc arthroplasty? Do you use cervical, lumbar, or both? And the third question is, do you use mechanical prosthesis with interlocking devices, or do you use viscoelastic prosthesis? So thank you to answer these questions, so we know each other, and I let you know the results of this small survey. Well, now we are, it seems that a few people are answering, not much yet, so we'll have the opportunity to answer the survey during the webinar. Now we can get started with the first communication. This communication is from Patrick Tropiano from Marseille about the lumbar prosthesis. Thank you, Patrick. This is your turn.
Thank you, Marc-Antoine, to give me the talk. It's a really pleasure to share with you tonight this webinar. Yes, importance of post-operative protocol in lumbar disc replacement. It's a huge question, and you know that intervertebral discs provide constrained mobility to the spine and serve as the primary stabilizers of the functional spinal height. The generation of the intervertebral disc increased after 40 years of age and is a common cause of chronic low back pain. Functional spinal unit cannot tolerate body loss at rest, and movement becomes a source of pain. Until recently, fusion surgery was the criterion standard. Disc replacement surgery aims to conserve physiologic movement at the segment involved in the motion, and rehabilitation procedures have been recognized as a necessary factor for a favorable outcome. Lumbar pain due to degenerative disc disease with time destroy the entire kinematic chain. Reason why Pot Physiotherapy is important. Specific training of trunk and limb musculature is crucial to gain maximum spinal and postural stability, balance, and energy transfer throughout the body. But there is no consensus between surgeons due to the surgeon's varying opinion. Important aspect of the postoperative protocols emphasizes sufficient healing time and a gradual return to normal activity to allow for good device to bone incorporation. The post-op protocol, there are four key aspects. The first one is early ambulation. The second one is use of a corset or brace. The third is the steps to return to normal activity, and the fourth is return to work. Early ambulation. This is general agreement in the literature that patients undergoing disc replacement will benefit from standing and walking as soon as possible following surgery. In my practice, patients stand up the day of the surgery. Use of corset or brace. There are some varying opinions on the use of bracing. Some surgeons believe bracing is not necessary, while others may prescribe bracing as needed for patient comfort. I don't know if you remember the time of the charity. A study was done in the 1980s years about brace and motion after disc replacement. And with the charity, patient with brace has lower range of motion than patient without brace. For the ESP lumbar, in my practice, a custom-made brace is used for 4 weeks to avoid torsion and twisting movement. The soft belt could be wear for more 3 weeks. And I didn't observe a loss of range of motion with brace with the ESP during my experience. Third, the steps to return to normal activity. There are 4 phases. The phase 1 is active rest phase. Patients were mobilized with the help of the physiotherapist on the first post-op day. Patients should keep mobile, change the position frequently, and should not sit in the same position for more than half an hour. Maintaining the correct posture was explained to the patient on post-op day. Patients were instructed to avoid lumbar hyperextension and keep the back straight. Do's and don'ts after lumbar disc replacement surgery. Not rotation of the lumbar region for the first 3 weeks. No curving of the lumbar region for the first 6 weeks. No intense abdominal exercise for 6 weeks. No participation in competitive sports for the first 6 months. Avoid lifting, twisting, and hyperextending for the first 6 weeks. Try to keep back straight. Can swing after 6 weeks. Can jog after 6 weeks. And can drive after 2 weeks. The phase 2 is early protective phase. It's during 4 to 6 weeks. This is the pelvic tilt exercises started in pain-free limits, and the patient should walk as he wants. The phase 3 is a dynamic phase. It's during 7 weeks to 6 months. This is a core strengthening exercise according to patient tolerance. Dynamic lumbar stabilization exercise is started in pain-free limits. Any exercise that causes an increase in pain must be stopped and excluded. Kinetic chain exercise program, including proprioceptive exercise, was individualized according to the patient. The phase 4 is back to the sport and walk after 3 to 4 months. Patients were allowed to participate in sport activities. Activities involving low resistance, height repetition were preferred. Contact sports were allowed, but the risk of falling and impact were explained to the patient. Patient's preference was an important determinant of choosing sport activity. Special precautions are taken according to the preferred sport activity, and training program is individualized. To have a dog is also very helpful for this kind of exercise. Special recommendation for return to work. This depending on the type of work. For those who have office works, 1.5 to 2 months is the rule. For EV workers, 3 to 4 months is the rule to return to work. What I am doing. In pre-op, I'm asking the patient to perform muscle strengthening and stretching to be prepared to surgery. I think it's very important to ask to the patient in pre-op to do some exercise to arrive for the surgery in a good shape. At the end of surgery, when the patient is still on the operating table, I flex the hips 5 or 6 times for fixing the prosthesis anchorage. During the first 6 weeks, patient wear a brace. They have to avoid extension, torsion, and twisting. Flexion is permitted without restriction. Flexion stabilizes the prosthesis. Sitting position is permitted just after the surgery. Sitting position is stabilize the prosthesis also. Walking is allowed without no limit. Sexual activity needs precaution to avoid great movement. After 6 weeks, return to work average 4 to 6 weeks, but could be up to 12 weeks depending on the physical demands of the job. Physical therapy should start right after surgery and continue through about 6 weeks. A gradual progression of Nordic walking exercise and limited weight exercise, max 10 kg, were typically prescribed starting around the third day post-op. Full sports activities were not recommended until after 12 weeks. In conclusion, management of the post-operative patient following TDR varies somewhat among surgeons. It is up to each surgeon performing TDR to base their own post-operative care on their own knowledge and experience of the device, surgical procedure, and patient characteristics. However, one goal remains constant: sufficient healing time and limited activity to allow for good device-to-bone incorporation. A good result is a combination of good indication, trained surgeon on the device and technique, aware of specificities of the device, ready to follow the device guidelines, and ready to follow the recommendation of the spine innovation. And you have on this slide the link where you can find the recommendation of spine innovation for this prosthesis. Thank you for your attention.
Well, thank you very much, Patrick, for your very clear presentation. Well, first of all, I would like to tell again, if everyone wants to go to the poll button to answer the question and to vote, so we get to know each other. It seems that in our audience, most people are already use prosthesis, and they use both prosthesis for the majority, but the cervical is seems to be the level that is mostly used, and 2/3 are viscoelastic users rather than interlocking device. There is another, and I would like to people know that they can use the chat to ask questions directly through my voice to the speaker. And again, there is 2 questions about this presentation. So we get to know if you use a brace, when do you let your patient go back to sport? Because I think this is very important here to tell that there is absolutely no consensus. There is no guideline for the post-operative care. And I'm glad you made your presentation, Patrick. So because it seems that you have 3 phases. The first phase is the post-operative time, right away after surgery, and to make sure that the prosthesis will fit between the vertebra. And then you have a first part, which is, if I have a good understanding, it's about 6 weeks. And these 6 weeks is a time for the brace. It's a time for paying attention to avoid specific movements. And then you have rehabilitation. So my first question would be, what movement are the worst? And I see that you can sit early, but what would be the worst motion that shall be avoided by the patient in the first 6 weeks?
With the ESP, the worst movement are hyperextension and twisting and rotation, the same. Okay, those hyperextension for 2 reasons. One is for healing, because anterior surgery, the healing is anterior. Then it's painful. If people are doing hyperextension, they will be painful on the scare. And also, this can mobilize the prosthesis in case of posterior closure of the disc space. We're all aware about the risk of twisting and rotation with the ESP, that we have to avoid this kind of motion. And sitting is a flexion of the spine. Sitting for me is recommended position more than the others.
Because compression is pretty useful to fix the primary fixation of the prosthesis. Well, it seems that the answers to the survey shows us that people may not use a brace after surgery. It's like half-half. That's interesting to see that we all have different habits. And I'm sure this is a part of the result, because we have a short-term result and a longer-term result. And what we want is the osteointegration of the prosthesis. So I see that there's a question on the chat. Is there an age of patient condition for which prosthesis is contraindicated, leading to simple fusion? Do you want to answer, Patrick, this question? If there is an age limit for surgery like this?
For me, there is no age limit. There is a bone limit, bone quality limit. And most of the time, I'm using DEXA in the patient in pre-op to check if the bone quality is perfect for the disc replacement. In case of doubt, I can add some cement. But for me, there is no really age limit for disc replacement. It depends of the not of the age of the patient, but more of the physiological ages of the patient. A patient with 60 years old, with a good shape and very active with ideas, we can put the disc replacement. And what I say that the viscoelastic prosthesis is not a motion device; it's a stabilization device. Then it's different than bone and socket prosthesis, where you can have some posterior arthritis. There, in case of posterior arthritis, we stabilize the disease, and this avoid any kind of complication and disadvantages of the mechanical prosthesis.
I see your point. That's
viscoelastic prosthesis. In fact, the limit, the age limit, increase if I can just,
Yeah, it's a non-fusion procedure that is stable on its own because of the viscoelastic properties with the shock absorption and one-piece implant.
It's more stabilization than motion.
That's why there is an alternative to fusion even in elderly patients, as long as the anterior vertebra can support it with the cancellous bone. There is another question regarding the size of the prosthesis. Is there any difference in your post-operative prescription regarding the size of the prosthesis in reference to the size of the patient and probably?
No, it depends on the way of the implantation. There is no restriction depending on the size of the prosthesis. The prosthesis, the size is always the same. Then it depends on the technique of the surgery, not more the size.
I think we need to be aware that we want to place a prosthesis that's going to fit in the intervertebral space, and that may distract a little bit, and we may have some sciatica for a short while after surgery, which is normal.
More distraction pain due to the muscle, ligaments, capsule. It's referred pain. It's not really sciatica.
Okay, good to know. That's why this post-operative period is of most importance to fit the primary fixation of the prosthesis.
Yeah, the second advantage of the brace is to fix the spine and then to reduce the amount of pain with the distraction pain and all the problem that can occur with the surgery.
Have you seen long-term complications from arthritis facet joints in the same level?
No, I never said. Even with the mechanical prosthesis.
Okay, then I think time is flying.
For my own, I think that facet arthritis problem is more a problem from US surgeon than for us. It's not. I'm not kidding for that. I did a lot of surgery for the facet. When I was young with my mentor, we did a lot of things on facet. And each time we did something on the facet, patient was fine for 6 months, and then after the pain was recovered. Then the problem was not the facet. The problem is always the disc, not the facet.
Okay, thank you very much for.
There's a way to find an origin to a pain that nobody understands where the pain is coming from.
And very, very shortly, because time is flying, for the long term, for the later term, you recommend to go back to sport after what time precisely? 4 or 5 months after rehabilitation program?
Well, 3 to 4 months is for me.
3 to 4 months. So people,
depending on the sport, this is only for swimming. Swimming, they can start 2 months after the surgery.
okay, and rotational sport is more aggressive. Okay, well, thank you very much.
I'm just contraindicating one sport, is skydiving.
Why?
Because if they fall on the buttock, the risk is to impinge the prosthesis into bone and then to destroy everything.
Okay, don't do that. And
I'm
also,
contraindicating skydiving.
yeah, sky jumpers, no more. Well, thank you very much, Patrick Tropiano. Then we go from the south of France, Marseille, to Cologne in Germany for Dr. Biren Desai. And Biren, you have the talk about the cervical prosthesis. Thank you very much, Biren.
Okay, first of all, good evening to all of you. Dear Marc-Antoine, thank you for the invitation for this webinar. I already followed the first and second webinar meeting, and I think it's very valuable and beneficial for surgeons who want to learn more about the procedure with total disc replacement and their advantages, as well as the experiences until now. So here are my disclosures. I was trained as a general surgeon and orthopedic surgeon and trauma surgeon as well, and was able to perform more than 1,000 lumbar discs and 2,000 cervical artificial discs myself. During the last 20 years, I've been able to gain experience with intervertebral disc prosthesis of different types, designs, and brands. During this time, I developed a treatment algorithm that focuses on clinical outcome and patient safety. On the following slides, I would like to present my principles and challenges after cervical disc replacement. When does the post-operative course start? So I think after wound closure, post-op care starts and begins with quite simple things like using always a retropharyngeal drain. Remember, due to the preparation, you pass many vessels. Bleeding of different veins may result. Epidural veins, jugular veins, segmental vessels, or thyroid superior artery, to name a few. Also, when using the Casper retractor, the pin spot may bleed after the screw has been removed. Using a soft collar, the size must be measured pre-surgery. You have to measure the size between the chin and the breast, and you have to make sure it fits proper to limit motion after surgery. We check our patient before he leaves the OR if the brace is fixed proper, and we always use the retropharyngeal drain. Before patient leaves the operation room, we check if the drain is proper fixed and the drain bottle open. So why using the soft collar? It is recommended after cervical disc prosthesis implantation to limit movement of the cervical spine and improve bone integration. Several studies have shown that the bone integration is improved by coating with HA, hydroxyl apatite. We are currently assuming that the bone integration has reached the strength of 80% in the first 6 weeks after implantation as a result of bone growth. Post-operative, check the patient with neurological examination and control the phonation. First night, my patient is controlled and observed on the ICU. The drain can be blocked or occluded at the top, so bleeding may occur and the problem cannot be identified. Dysphagia and dyspnea may result. In normal post-op situation, drain will be taken out after 1 day after surgery. AP and lateral X-ray will be done, and the physiotherapist will start local massage, electrotherapy to reduce neck and shoulder pain due to the segmental distraction of the spine. Most restrictions I recommend for patients are for 6 weeks, like self-driving the car, swimming or cycling, hyperextension in the neck, heavy lifting over 5 kilograms. only isometric training for first 6 weeks, and contact sports are allowed after 12 weeks. Wear neck brace for 3 weeks and then, depending on the compliance of the patient, another 3 weeks. Bone integration is expected 6 weeks post-operatively, so I see my patients 6 weeks after procedure and control by X-ray and clinical examination. There is one challenge and complication I want to focus on. It's really rare, but still can happen. A 46-year-old female patient was planned for surgery in 2 levels due to neck pain, disc herniation, arthrosis. Operation went smoothly. Due to the protocol, she was observed on the ICU. Monitoring after surgery, patient complained mild symptoms of coughing. Pre-existing pain was gone, neurological examination was quite normal, and an X-ray was performed. We found an increase of the distance between the trachea and the spine. Revision surgery was initiated and about 180 milliliter of blood clot was removed. No active bleeding was found. 2 drains were inserted, and a couple of hours revision was done. Revision drains were taken out, and X-ray was performed and showed nearly a normal anatomical situation post-surgery. The literature has repeatedly challenged the use of surgical drains following many procedures, and there are currently no guidelines for determining which patients are most likely to benefit from drain placement after cervical disc replacement. So nonetheless, neck hematoma is still possible, even with a drain use. After cervical surgeries with total disc replacement, patients should be closely monitored. Although the risk of secondary bleeding is rare, it requires a rapid and consistent action. Drains can help to detect bleeding, but they are not a guarantee. A soft collar is recommended after cervical disc prosthesis implantation to limit movement and improve bone integration. Thank you for your attention.
Thank you, Beren, for your very clear and pleasant presentation. Well, it seems that very few people use the survey, but nevertheless, the one who does tells us that they don't automatically use a cervical collar after surgery.
Yeah.
I have to say that in my practice, I use it also, as you do, precisely basically the same thing. I really believe that the soft collar is strong enough as long as the size is correctly designed for the neck length. Well, I have a quick question about the bleeding. You insist a lot about the first phase of the post-operative care, which is the bleeding and the risk of suffocating hematoma. Do you think it's a limitation for ambulatory surgery, one-day surgery?
I don't think so, because as I showed you, the bleeding of maybe the superior thyroid artery may come later on, and it's very severe, and it may bleed, and the pars membranacea, which is behind the tracheal ring, it may be compressed, and this is a very severe situation. It has to be detected, and I'm a strong believer of one night on the ICU for all my patients, even if it's only one level disc. Okay.
Yeah, we have in my institution we have a protocol for 6 hours in the post-operative room for checking for this. That seems to be a little lot, but once it happens, it's very rare, but it happens.
Yes.
And it's not only a bleeding, in my opinion, from the vessels, as we can imagine, but from the bone itself. And I don't know if you use the Caspar retractor, but that can be a source of bleeding from the cancellous bone. Well, there is a quick question. Someone says on the chat, do you use the collar night and day?
For the first 3 weeks, day and night, and due to the compliance of the patient, another 3 weeks only in the night. So I think if you take it too long, if you use it too long as a patient, you may see other problems. But if the patient is not compliant, I will just remind him that he had cervical disc replacement, and I limit his movements to round about 10 to 15 degrees in all directions. So this is enough. So they can still move their neck, so they are not fixed like this. But I think it's very useful and helpful to remind the patient, because normally they are quite lucky and happy, and the pain is reduced, and they want to move on and go on back to their work again. And just to remind them that they had surgery, so the bone integration is much, much better if you limit the movement for the first weeks.
Well, we have a question about the flow seal, Surgiflow, the hemostatic powder. Do you use that systematically?
I use flow seal sometimes if there is any kind of bleeding from the bones. So if you take out the retractor pin from the Casper retractor, and then I will give a little bit of bone wax, and in some cases I use the flow seal as well to stop the bleeding. But mostly the bone wax is enough. As well, the front part of the vertebra, if there is a little bit of bone growth we take away, then I seal it with bone wax to avoid any kind of hypertrophic ossification.
Which is another point from the bone bleeding. All right, outpatient disc replacement. I think we already answered this one. Can you tell again that you're okay with that, but you don't do it for yourself? That's right.
For outpatients, what do you think? Pardon me?
Do you do outpatients?
I do outpatients. I see my patient 6 weeks post-surgery in my outpatients room in my practice, but I check them only once, 6 weeks post-surgery, and then they go to their doctor.
No, the question is they can leave right away after surgery, not automatically one night.
Due to our DRG system, which is a little bit crazy in Germany, we discharge the patient day 3. So they have to stay 1 day on the ICU and then another 2 days on the normal care ward before we discharge. So
that's why.
Like this, if you discharge too early, you will lose money, and this is like it is. Even if you feel good after discharging, maybe after 2 days, I would not recommend to do it as an ambulant surgery.
But if you were free, as we are this side of the Rhine, would you let them go the same night, if you were free?
2 nights. I would leave the patient for 2 nights at least. Yes.
Okay, well, I do the same thing. We don't let them go right away. Someone asked about ICU, ICU intensive care unit. Well, I think this, you'll tell us, but the post-operative bleeding is such a scary thing, and you need to react very, very rapidly. If you had that before, I had that once. I can tell you, it's very fast. So ICU is, in my opinion, is recommended. What do you think?
So our intense care unit is more like an awakening room. So we want to observe the patient very, very clearly. So on the normal care ward, there are more than 35 patients on one ward. So on the intermediate care, there are only 6 patients. So they are double checked with 2-3 nurses. So this is fine, and I can sleep well after this.
That's important. Yeah. That's important too. To do the next one the day after, in a good shape.
Yeah. Well, so the next morning, next morning they will be checked. I take out the drain. They receive the X-ray. I do clinical examination documentation as well. The phonation has to be checked, and then patient will go to the normal care ward, and they receive the local massage and electrotherapy for the shoulder and neck pain, which is quite common due to the distraction in the cervical spine. So if you do only 1 level, it's not so severe, but if you do double or 3 levels, it might be a little bit severe because of the distraction in each segment.
And I have a quick question about rehabilitation. I think it's in this first period of time when you have the collar, you don't move much, so the prosthesis is going to be fixed. Then you do isometric strengthening of the muscles. So
Yes.
do you teach the patient to do it himself, or
Yes.
do you need to send him to the practitioner to have some messages? And
Yes.
why do you do that?
So first of all, we show them how to do the isometric training. It's quite easy, as you know, and the PT will be advised to do the local massage, electrotherapy. We don't want to have heat in this area where we have been done the operation, but they can use a little bit of red light or something like this to lose the muscles as well. So they go to the physiotherapist, but only for local massage and electrotherapy.
Okay, well, thank you very much. I think we stop here because we need time for the last part of the webinar. I have just a very quick question for you before we let the cervical on the side about the driving, the ability for driving. When you say you don't want to drive within 6 weeks, is it driving yourself or being driven as a passenger?
No, driving by themselves. It's risk. It's not recommended because they have to turn their head to look in the back mirror, and even if there is any kind of accident, they won't. I don't like to have this situation because the disc is not bonded in the first weeks, and so they may do some rotation, and so the bonding will be bad, and they may have an accident. So if they are not self-driving and they wear their neck brace, they are allowed to go every day after surgery.
Okay, thank you very, very much. We stay tuned until the end for answering more questions if needed. Well, the next speaker is Professor Jean-Yves Lasnec from Pitié-Salpêtrière in Paris. And you were going to present us a case, a very specific case that is a source of interest, will be a source of interest for all of us because of the complication that you describe. And Jean-Yves, this is your turn, please. Go ahead.
Okay. Thank you, Marc-Antoine. I shall present you a failure. Failures are very interesting because we learn a lot of things. We learn about what we did and what we did not do. So I present you this woman, 35 years old, a classical history of low back pain. And you see the level of disability on the right, preoperative. So she's very active, perhaps too active, you will see. And she was treated for more than 1 year with medication and physiotherapy. Something classical with narrowing of L4, L5. You see the modic change on the RMI, and you see there is a slight inclination of the spine on the large AP view. Now you have the EOS, and the EOS provide us an additional information. She is not imbalanced. She has quite normal incidence angle, and she is a little bit retroverted with sacral slope 28. So nothing very particular. Sitting position, because I do always sitting EOS as a research, but I think also it is very interesting to see the evolution of the patient and to understand some particularities. So she is not imbalanced sitting. What we can observe when comparing standing and sitting is the disc is very stiff and narrow, is very narrow in the anterior point of the disc space. Another detail, you see that the modic change is very particular. It is on the right side. Remember, she has a slight inclination of the spine. And so when you go from the left to the right, you see you don't see the modic sign on the left side of the vertebra on those sagittal images. I do systematically an angiogram, and you see she is classical, no particular, no specific complication to be expected. So this is a post-operative image, September 2015. We had no per-op or post-op problem. Perhaps you can criticize me. Perhaps it would have been better to push the prosthesis a little bit more posterior. But with viscoelastic, we know that with such positioning, we don't have problem. So she was in a good situation post-operatively, and we saw her. I see my patient 1 month after, no problem, and 3 months after, you see this patient in December 2015, and I discovered that this woman had a lot of activities, and I found that she was a cocaine user. So you can criticize me and say bad selection of the patient. I assume this, but perhaps it was not fully a contraindication. But the point was she did not use a brace. And I fully agree with Patrick saying that the limitation of movement postoperatively is something interesting during the bone ingrowth or the bone on growth period. And you can see that something worried me. You see a radiolucent line on the upper part of the prosthesis. In addition, and I am not sure it is a good sign, she had a bending, and you see that on the right bending, the position of the spinous process is slightly rotated on the right. Those two arguments made me a little bit anxious, and I asked this patient to wear the brace. Now you have the follow-up of the patient 6 months after the surgery. She is still in good condition. You have all of the parameters on the right of the slide. And again, despite she is in perfect situation clinically, she is very active, and you see that she has this radiolucent line at the upper part of the implant. So I was anxious, and she was lost for follow-up for 5 more, a little bit for approximately 5 years. You see, she became homeless, living in a car or in the streets with a lot of drug and alcohol use. And in addition, she had a severe traffic accident with an open forearm fracture. And what the information I got was a fracture of the upper L5 and plate. An impaction. I don't have the X-ray, but you will see what happened. This is what I discovered in June 2021. Impaction of the vertebra, L5, and mobilization of the disc, not in the sagittal plane, but mainly a kind of rotation and impaction. So we need to go in depth now in this case. She came with an RMI. You see on the plain X-ray, she has an hyperdensity of the L4 and L5 vertebra. There is an impaction in L5, probably the consequence of the fracture. And you see an hypersignal of the inferior plate of L4. But this RMI was a little bit disappointing. I want to share with you the analysis I did with CT scan, and I think it is one of the messages. Look at this. When you compare the image of RMI and the CT scan, you have much more information. You see the radiolucent line on the two end plates. So you ask yourself, probably there is no bone on growth or mobilization of implant, and you see a loss of bone material at the superior end plate. And you may ask yourself some question about the density of those vertebrae. So the question are, bone analysis, what about this cyst? What is the bone fixation status? Failure for bone growth, perhaps septic. And the last question, what about the implant alteration? Do we have bone loss due to wear, or do we have bone loss due alteration of the PCU? First question, bone analysis preoperatively. You see here the detailed image of the superior end plate, and as we use titanium end plate, we are able to have very precise analysis of the bone stock of the patient. And you see very well the loss of bone stock. This is the inferior plate. You have the cut through the implant, and you see also in the inferior plate, you don't have cyst, what I call cyst, but probably it is not the good word, and you have this hyperdensity. But we can be much more precise. We are able, with a CT scan, to analyze the density of bone. Patrick spoke about the DEXA to analyze the density of bone. We can use the CT scan as a tool to assess this. We have the density of the spongious bone, and on the right, I put the density of the spongious bone of other vertebra of this patient, quite the same. And you see the hyperdensity of the bone as a reaction. And you see it's a little bit less than cortical bone, but it is very dense. If we analyze the cyst, sorry, I want to go back. Okay, if we analyze the cyst, you are also able to analyze the inside. And you see that the density is about 53, 65. It is even 44 like blood. And you see a kind of false membrane inside of this cavity. So for me, before doing the resurgery, it was blood, and probably it was serohematic liquid inside of the cyst. So what I did, July 2021, I did a one-stage surgery without technical issue. Stage 1, posterior fixation, because I was a little bit anxious about the difficulties to correct the frontal plane. And after, I did a replacement of the prosthesis by a cage. I don't show you the further slide because it is not important for our discussion. She is well now. And what I discovered was very partial bone on growth. Bone loss, the inside of the bone loss cavity, I had blood and a peripheral membrane, as we see in hip or knee cyst. I am also a hip and knee surgeon. It was exactly the same aspect as we have around our hip or knee prosthesis sometimes. No macroscopic inflammation and no macroscopic implant deterioration before extraction. So I tried to keep the implant intact to analyze this implant. So what about the bone on growth? I had only very limited bone on growth, as you can see. No more hydroxyapatite. It's normal because of the delay. Only small bone on growth. But one of the message was, on the 3 weeks late culture, we had positive samples. All the samples were positive for Propionibacterium acnes. We call this now QT bacterium acnes. So we treated with this patient with 6 weeks amoxicillin, which will be, perhaps we shall discuss about this, because it is not very classical for hip and knee prosthesis contamination with propionic. So it worked very well. What about implant alteration? Probably you are waiting about this. And unfortunately, I had to damage a little bit the implant. You see here the places where I put a very strong tool to remove, to track the implant. But I had, before the extraction, no argument from visual observation for a lesion of the implant. And in addition, when analyzing the implant, we put a lot of attention on the top shutter to see if it was still well sealed and to see if there was some correlation with the bone loss in the inferior end plate. What about the status of the PCU? You have the spectrum of the PCU of the implant with a black rectangle, and you have the reference spectrum. It was exactly the same. No, we can affirm that there was no modification of the PCU. Histologically, we did not find hydroxyapatite particles in the surrounding of the implant and no inflammatory reaction, which is strange perhaps, but which is classical also in propionic infection. So what did I learn from this case? First, the likely scenario was doubtful bone on growth. This patient did not accept the brace, and I was very anxious since the beginning. probably a worsening of the situation by this asymmetrical compression fracture of L5, and additional delayed septic complication. Delayed or not delayed. We had a perfect follow-up. We did not have any doubt during the first 6 months, but we know that with Propionibacterium acnes, it may be a question. So my first message is, if you have to remove a disc replacement, whatever the type of implant is, we need to do late culture. Second thing, CT scan is more contributive than RMI for those lack of bone. It is not perhaps clear for spine surgeon, but it is very clear for knee surgeon. I took this image from classical literature for knee cyst, for example, and you see in the middle, we have much more information from the CT scan, the density, you have the density inside of the cyst and inside of the reaction around the cyst. Probably there is a new focus regarding the bone adaptation regarding implants, because we have a lot of patients with not perfect disc and plate. They are curved, concave. You can see on the arrow in those degenerative discs, if you pay attention, you have a lot of such cysts in the hand plate of degenerative discs. So it is very interesting to use a CT scan for this. And there are some papers. This paper, I put the reference in European spine, showing the importance of the analysis of those hand plates because of the risk of mismatch between the hand plate and the implant. It is a problem, for example, for keel implants. Look at this case. 1 month, I am still anxious because there is a radiolucent line. 6 months, it's much better. 5 years after, completely healed. And it is my experience in patient with acceptation of the brace. And the last thing is regarding this bone adaptation for disc implant is what is called the external hydraulic theory. It is used for knees, for example. It means that if you have an end plate and if you have a space, you have fluid intrusion and from holes or from the space, and there is overpressure between bone and the end plate. And this may induce as a consequence the creation of those bone loss. So we must be very careful for the preparation of the end plate. And in my experience, the inferior end plate of L4, for example, or the inferior end plate of L5 are sometimes difficult to prepare because we don't see very well during the surgery those end plates. Thank you for your kind attention.
Thank you very much, Jean-Yves Lasnec, for your presentation. This is a weird case, I shall say. We have very few room for, because it's late, but how often do we see this type of complication, and are they more prevalent in viscoelastic or mechanical? What do you think about this question? Have you seen that a lot?
No, it is completely exceptional for me. And it is an accumulation. I choose this patient because it is an accumulation of septic problem. So we must be aware of delayed or late infection as we have for hip and knee prosthesis. Secondarily, I fully agree with Patrick saying that patient must be limited for the activity because, as Byron said, we need to have bone on growth, and it is biology. And we know this from hip and knee. We need to have a limitation of the micromobility between the implant with hydroxyapatite and bone. It is a condition to have bone on growth. And the last point, of course, is the preparation of the end plate. And perhaps another message, very often we forget the CT scan. We can have a lot of information. And fortunately for implant with cobalt chromium end plate is difficult, but for implant with titanium, we have a lot of information. I choose this case because I think it was very interesting because of all of those details.
Yeah, thank you very much. It's very interesting.
It's exceptional for me. It is the only one until now.
Absolutely, because we always pay attention to the mobility. Is it mobile? Does it move, and so on? But in fact, the growth, it's a prosthesis as any other prosthesis with no cement. So my question would be, when you see that, is there at like 6 weeks or 1 month at the first appointment, then is there a possibility to do something, or do we just
I
follow?
think for a cementless hip prosthesis, we have a first stage, which is the problem of primary stabilization. Primary stabilization, we do it ourselves, but with good preparation of the hand plate, good choice for the implant. But it is also the responsibility of the patient. So I explain to the patient, it is the responsibility of the patient to respect the brace and the limitation. And then we have the secondary stage, which is the final stabilization of the implant. So I think it is very important to explain this to the patient. And I fully agree with the 6 weeks frontier for this.
Well, we have a very quick question from the chat, but we have very few time just to know that it's discopathy is sometimes asymmetrical. It's not really a scoliosis, and discopathy is asymmetrical on the X-ray. That's basically it. Obviously, it's not a prosthesis in a scoliosis case. Well, thank you very much, all of us. I'm not sure we have time for a round table, unless Patrick or Biren want to comment and take the speak again.
I just want to have one short question, Jean-Yves. Did you change your protocol intra or post-operatively due to the late infection you have seen? Is there any change in between your surgical procedure? Do you use local antibiotics, or do you give your antibiotics for a longer period of time, or did you completely change your protocol?
It's very interesting to look at the literature regarding propionic. Our classical antibiotics we provide as antibioprophylaxis don't work on propionic. It is the same problem for hip prosthesis. Yeah. So it's a problem. We did not change anything about this.
Okay.
But the message, if we remove an implant, do late culture.
Yeah.
Well, thank you. I need to conclude because we want to respect the timing. So the take-home messages from Patrick, Biren, and Jean-Yves are basically that the success is a result of a good combination of selection of patient, good technique, and then having a follow-up that is very attentive for the early post-operative period, and for the primary period of primary fixation in the first 6 weeks. Biren insisted on the risk of bleeding in the cervical spine, which is rare, but it's always something to be. We need to have a focus on this all time, because that may happen, and that is very dangerous. And at the end, Jean-Yves Blasnek told us about one case showing that it's not only a matter of local and segmental mobility, but rather a situation with a sagittal balance, and the key parameter of the bone fixation at the early process, and we need to pay attention to that for a long-term good result. Well, thank you very much, all of you, the speakers. You were fantastic tonight, and thank you to all the attendees. We shall see us again, maybe a next webinar someday, because we like doing it. The Spine Arthroplasty Committee of the GECO is very dynamic, hopefully. And I want to tell you that we have a GECO spine course physically in Le Mans. So if you're interested, please contact us, and you are all invited to Le Mans, which is nice in France. If you don't know, you will visit a nice place. And see you soon. Have a good evening for those who are in Europe. Thank you again.